Okay. So I begin in the name of Almighty God, who is the most gracious and most merciful. Good morning, afternoon, or evening, wherever you are in the globe. You're welcome. Salams and greetings to you all. I feel extremely honored and privileged to welcome you all to this seventh webinar program for the year 2023-2025. And before we start webinar, as traditionally, we usually talk a little bit on DFood International and followed by introduction of our speaker, and he will take the platform. So I start with the first slide. DFood International is a mission with a vision. It's a registered international non-profit association under Belgium law. DFood International is a global organization, consists of people working in the field of diabetes-related food complications or are related in providing the food care. These people are spread across all 7 regions in the world. And we know these 7 regions. It is Sub-Saharan Africa, South America, and South and Central America, Middle East and North Africa, North American, Caribbean, Europe, Southeast Asia, and Western Pacific. We have board members, regional chairs, regional advisories, country representatives, and then full members from all these 7 regions. Our mission to promote a global profile of diabetes food prevention care through awareness, guidance, education, research, and professional development, and obviously it's ending avoidable lower limb amputations due to diabetes worldwide. Our goal is to improve, to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their lives. Our focus of actions, obviously training the healthcare professional mostly at the grassroots level, how to manage the diabetes-related food problems effective and prevent amputations, giving healthcare professionals strategies to implement, develop, and sustain the food service, promoting the recognition of diabetes food specialties in especially low and middle income countries. Closing the gap of available and affordable diabetes food care and mostly applicable to low and middle income countries. Activities during 2023-2025 or programs. There's a whole list of programs which have been occurred, and most of them have already been finished between 2023 and 2025. And 2 of them are flagship programs which happens almost every year. So train the food trainer courses during 2023-2025 and World Diabetes Awareness. These were all 5 train the healthcare professional courses which were done and have been already there to be done and have already been finished and over. And these are just to show you. The first one was in SACA region, then followed by Western Pacific region, Europe region in February last year, and then in Sub-Saharan Africa, followed by MENA region, which occurred in Karachi, Pakistan. Then we have World Diabetes Awarenesses, which runs for 1 week, and one day we have a global meet. So we already done this last year, and the next one would be done under new administrations. The brochures in several languages been there. In all of them are there. These are newsletters, which already 7 of them have already come, and the last one which will come very soon in next month. So all these programs have already been done during this our time. Webinars and every 3rd month, after every 3 months on Saturday between 2 to 3 p.m. Central European time. And these are all done. And today we are doing the 7th one. The Jaap is there. The last one, which will be closing one by Seco Bus. So that's a very nice. We actually started, I remember, with Nicholas, and we're going to finish with Seco. And these are all links. Whoever is interested in any education material, it's free to download anytime. Our 3rd DFood International Conference and 8th Biannual General Assembly is in May, between 9th to 11th May, and it will be in Malaysia, where President-elect will take over from me. Today's registration was 224 delegates from 58 countries. And let's see how many of them would attend. So usually panelists are all board members, regional chairs, advisory boards, and sometimes we have guest panelists. The whole event has been financed, sponsored by Urgo. So thank you very much to Urgo. Now I introduced Jeff. We feel extremely honored and privileged to introduce the speaker for this seventh webinar education program for the year 2023-2025. Jeff, he works as a senior research human movement scientist at Academic Medisch Central University, that's AMC, Department of Rehabilitation Medicine, Amsterdam, Netherlands. He also works as an associate professor at Queensland University of Technology in the Institute of Health and Biomedical Innovation, Brisbane, Australia. Jaap is a human movement scientist from Netherlands, specialized in clinical research on foot disease. His research focuses on interplay between biomechanics and behavior in prevention of foot ulcers and amputation. This includes real-life and laboratory gait activity analysis, communication strategies, footwear optimization, and e-health solution for disease detections and behavior changes. Jeff has a research and clinical experience from academic and non-academic research setting in Netherlands and Australia. He's a senior research at University of Amsterdam. He coordinates, supervises, and performs numerous research projects on diabetic foot disease. Clinically, he works as a human movement scientist in gait lab, measuring, analyzing the plantar pressures, physical activity adherence in patients who visits multidisciplinary diabetic foot clinic at the centers. And he has got a lot of research papers on his name. He also serves as a scientific secretary of the International Working Group in Diabetic Foot, editorial board and prevention working group responsible for the international guidelines on diabetic foot disease. We feel extremely honored and privileged to welcome our speaker, Dr. Jaap van Netten, for this seventh webinar, Prevention of Foot Ulcers in Persons with Diabetes according to International Guidelines 2023. So all the questions can be posted in Q&A sections during his talk, and we will discuss it. Thank you. Okay, Jaap, you are most welcome now to take the platform.
Thank you so much, Abbas, and thank you for not only this opportunity, but also this very kind introduction. And it's always a bit strange to hear all this being said about yourself. But I feel really honored to be here. And I just looked at the panel and seeing people from all over the world coming here to this webinar to listen what I will try to tell you about the prevention guidelines. But I also try to bring it a little bit further, because you can read the guidelines, but there's also always parts that you can't read. And I hope to present those and generate the discussion on, well, what's next in ulcer prevention and how do we go to personalized medicine? And that's also the topic that it would be great if we could have a little bit of a discussion at the end. And I'd like to compliment Abbas also. He was showing in the slides the cost study. And for those who haven't seen it, I think it's been published 1 or 2 weeks ago together with Professor Dattaria, and it was a really, really good paper to read. So well done, Divut, on getting this out there. And those who haven't seen it, yeah, really suggest you should read that paper. I told all my PhD students they should be doing that. But that's not today's topic. We're here to talk about guidelines on prevention and personalized medicine. Some disclosures to start. I've been promoted because they couldn't get rid of me in the IWGDF, so now I'm the vice chair of the IWGDF, with now Frank Game obviously being the chair and having to chair the prevention working group for its next update. Within the Netherlands, I'm the chair of Academic Workplace Homeland, which is an organization where we try to implement evidence in daily practice. And it's really on that line between evidence and daily practice that I really like to work. And all our research could not be possible without research grants, and these are the biggest funders of all our research. Probably well known in this group, but still worth to sort of keep putting this forward. Peter Lazzarini from Australia, where we work with, is really good in finding out the epidemiology and getting the global burden of the disease, because actually with the Lancet, this is a huge study. It's probably one of the biggest study globally that tries to estimate for every disease in the world the global burden of that disease. And here you can see the top 5, and then type 2 diabetes at number 8, so ischemic heart disease, respiratory infections, COPD, and all the way up to 8 is type 2 diabetes. And let's not discuss sort of the exact meaning of global disability adjusted life years, but it's important to realize that type 2 diabetes is number 8, which is not unexpectedly. But what we then did is dive into that and find out that within all this information, there's also quite a lot about foot disease. And if you separate that from diabetes itself, the diabetic foot disease in itself is the 13th disease globally with the burden. So we have every reason to spend every single ounce of energy that we have in trying to reduce this burden, because it's a huge burden all over the world. But obviously, I'm preaching to the converted here. You all know that. But I do think it's really helpful to have the data and to have the numbers to actually show that to your ministry, to show that to the people in your country that this is a huge problem everywhere. And we need every inch of energy that we can manage. And one of the key challenges in there, and you've all seen this graph thanks to David Armstrong's work in the New England Journal of Medicine, one of the key problems is not only the ulcer and preventing amputations, but then once you've healed it, the chance of that ulcer coming back is so huge. Within a year, around 40%, within 3 years, more than half of patients, everybody keeps getting an ulcer again. And that's obviously my area of expertise, where we try to, how can we prevent these ulcers from happening? Because that's the big question underlying all the work that we're doing. How do we reduce this burden of diabetic foot disease? And obviously, you can start at the back end by healing diabetic foot ulcers or healing them quicker. That definitely reduces the burden. You can prevent recurrence, because the easiest ulcer to heal is the ulcer that never was there. We can also try and move even further forward and prevent the first ulcer, or even further forward and prevent neuropathy. But we also have to accept here that there are already millions of people out there with neuropathy, hundreds of millions actually, and they're only going to come more, because we really don't know how to prevent neuropathy. Yes, it helps if your diabetes is managed better, but we have to accept that these people are coming to our clinics. So the question is then, how do we reduce this burden? Can we prevent the first ulcer? Well, we don't have much evidence. And the other question we still don't have an answer to, is it feasible and is it worthwhile? We have to spend a lot of energy in a lot of patients to prevent only a few outcomes. So I definitely think we should go there, but we don't have the evidence and we don't really know how to do that in a cost-effective way. Then preventing recurrence. That is probably the biggest bang for buck, as the Aussies like to say, in reducing this burden. But preventing recurrence, I've always said, requires you to be a smoke alarm. And a smoke alarm is something that I don't want to be, and probably most people don't really like to be. We much rather be the fireman standing out there and being the real saviors, saving that foot, that severely ulcerated foot that's about to undergo amputation. But obviously, the smoke alarm is much more important. One of the aims of this talk and of the next 2 years is to stop talking about the smoke alarm, because ever since I started talking about this, I've been haunted and jinxed by smoke alarms going off in the middle of the night. And I also think we should sort of promote people working in preventing recurrence. We're more than smoke alarms, but I'll get back there in the end of this talk. Because right now, if we want to reduce this burden, as I showed in the previous slide, we can heal them quicker, but we also prevent them. And it's the question is, where do we put our energy? And if you look right now, and we did this analysis a couple of years ago, but nothing has changed here, only 2.4% of all research trials in diabetic foot disease are on ulcer prevention. And compared to that, more than 70% are on ulcer healing, which means that we're spending millions and millions and millions of euros on creating these products that might heal them slightly quicker. And we're hardly spending a single dollar on making sure that the foot ulcer is never there. And that, I think, we have to accept. Time is limited, money is limited. We don't have any more millions of dollars. We need a better focus, and we need more focus on prevention. We need everyone probably getting into ulcer prevention. And one team that has been doing that for a while now is obviously with the IWGDF guidelines, and the reason that I've been asked to talk here. And I cannot thank this team enough, because as Abbas and many here can say, writing a guidelines is a team effort, and you need everybody here. And all the people on this slide work together with us in getting these 2023 guidelines on ulcer prevention out there. So some general data about those guidelines. Well, it's always important. What we try to do with the IWGDF is continuously update the guidelines, because the world changes and the evidence changes. And the recent guidelines always updates any preceding guidelines. So always use the most recent guidelines. For prevention, we're specifically targeting people at risk. So that means those with diabetes and at least loss of protective sensation or peripheral artery disease. As a guideline group and supported with many people, also many people in this audience from DFood, we developed 14 clinical questions that are the questions that clinicians at the call phase have to answer on a daily basis. And that's where we want to provide our recommendations. We selected 13 critically important and important outcomes because a treatment can have a different effect on different outcomes, and it's important to rank those and to realize what is the most important outcome for you. We looked at all the evidence, more than 150 studies. We did many meta-analysis and then summarized that all into 33 evidence statements. And based on that, 17 recommendations for clinical practice. And not surprisingly, because those key elements of prevention actually haven't changed much in the past 2 decades. We know what are the key elements that we need to do. It's about how we do them and probably also how we implement them and the subtle changes in all of that. But the 5 key elements, and this is also something that we cannot repeat enough, is first identifying the at-risk food. We have to know who the person is that is at risk versus a person whose risk is much lower. If you know who is at risk, then inspect and examine that more often, regularly, and we do provide specific guidelines there. Education for patients, families, and healthcare providers. Footwear, and make sure that appropriate footwear is routinely worn by all the patients, and then treating any risk factor that you see for ulceration. And best is to combine those in an integrated type of foot care to make sure where you consist at least 2 or preferably more of those elements together, because all these elements work together. They can't be seen separate from each other. So let's zoom slightly out. What we're seeing now in current practice and what the guideline here is talking about is called stratified healthcare. And I've drawn this sort of infographic, and I'll talk you through to discuss the strengths of stratified healthcare, but also some of the weaknesses to, well, what do we know now and where do we probably have to go? So stratified healthcare looks at the entire population and then perform the IWGDF risk stratification to create different strata. Because if we would provide all ulcer prevention treatment to all the patients out there, it would be completely overburdening. We would A, not have all the professionals, and B, it would be asking way too much from all the patients. And that's why it's really helpful to create different strata. Very low risk, moderate risk, and high risk, so that you can tailor the recommendations that you make and the treatments that you give to the specific risk situation of that specific patient. And what we have in the guideline, and what I'll talk to in the next few slides, are then the general treatment approaches for each of these strata. We have education, we have footwear, and we have risk factor treatment. And then the specific recommendations depend on the strata that you as a patient are in. And if you want to know more about all the evidence behind this, I suggest you read our systematic review and meta-analysis. But the biggest take-home message probably is, if you haven't done it, please read it. And if you have done it, it's probably worth doing it again. Read the guidelines on the prevention of foot ulcers in persons with diabetes. And what you will see there is, on the topic of education, 5 recommendations. And 4 of those recommendations are on education about self-care. All are strong recommendations, but with low quality of evidence. And it's important to realize that for education, there is no evidence that education prevents foot ulcers. Yet we continuously recommend, and we all do this in daily clinical practice. But it's something that we should all be quite humble about, is that yes, it is important to teach people and to educate people and to coach people what is important self-care, what needs to be done, but that does not in itself prevent the foot ulcer. You need a little bit more than just education. And one final recommendation here in this topic, where it is part of education, is coaching people on how to perform temperature monitoring. And obviously it's not only coaching, because you also need a thermometer. It's a conditional recommendation, so we're not as strong as the other ones, but it's actually based on moderate quality of evidence, because there are multiple RCTs showing that if you do monitor your temperatures on a daily basis, you will help prevent some foot ulcers. The second topic is footwear, and Abbas already showed you that Sikko Bas is going to be talking in the next webinar, and he'll probably dive into much more specific on footwear and offloading, which is his absolute core strategy, and we work together on a daily basis, and I'm so lucky for being able to do that. So I'll keep this quite short and brief. But for footwear, we have 3 recommendations, not exactly aligning with the strata, but more about the foot deformity that you see, because footwear is primarily aimed to redistribute pressure. So we have a strong recommendation based on low quality of evidence for those with no or limited foot deformity. Then things change when you have a foot deformity that increases the pressure, for which you have a conditional recommendation, again, based on low quality of evidence. But the big focus here is obviously those who have a healed plantar ulcer. Because if you have a healed plantar ulcer, you for sure will have a pressure increasing foot deformity, and you've already experienced the complications. And what I showed earlier, you have this huge risk of getting a new foot ulcer. So for those, we have a strong recommendation based on moderate quality of evidence, because there's quite a lot of research going on in that specific topic. And then the final part on current practice are the 6 recommendations on treating risk factors. And the first one is a strong, even though it's based on very low evidence, and it's one that we keep finding also in our studies, is that we have to treat pre-ulcers. Pre-ulcers are the pre-stage of an ulcer and also one of the biggest risk factors. And it's something that even in the Netherlands, I keep seeing patients who come in our clinic with a pre-ulcer, and then for some reason we don't see them back on a weekly or bi-weekly basis, and then 1 month later they're there with this huge ulcer, and you go like, we knew this was coming. We knew we could have prevented this probably, because if there's a pre-ulcer, treat it until it has completely gone away, because that's the only moment that you know that you've saved that foot from preventing to getting into an ulcer. But it's something that the patients not come, or we as clinicians are sometimes a little bit too easy with that. Also myself looking in the mirror and realizing that we have missed some of those. That's why I keep emphasizing them. Any pre-ulcer, treat it until it's really gone. When you have clotose, flexor tenotomy is an option, and thanks to the work from Denmark, from Jonas Andersen, we now have an RCT showing that it really works. But you can also put an orthosis to help redistribute pressure in that area. On another surgical topic where there's a lot of debate and studies, we do feel compelled to say have a negative recommendation that there's no reason to perform a nerve decompression, because the evidence really does not stack up against the risk that you take in with a surgery like that. And the other side, again, something where there's quite a lot of evidence is on foot ankle exercise programs from various countries where podiatry may not be always there, but physical therapists are there. And one of them is Isabel Sacco, part of our group, where we do see benefits from undergoing foot ankle exercise program or giving people mobility advice to help them navigate this complex disease that they have and be able to actually walk more without getting a foot ulcer. So summarizing again, this is what we have in the guideline. 5 key elements of prevention: identify the foot, inspect and examine them if there's a higher risk, and then the 3 core parts of treatment: education, footwear, and risk factor treatment. But as I said earlier, we somehow still seem to fail in properly prioritizing ulcer prevention. There is so much evidence and so much money going into healing foot ulcers, where if the foot ulcer isn't even there, we don't have to heal it. And we did an analysis together with Jim Woodburn and Sikko Bas in what do we think, why are these barriers in place here? And one of the first things we're seeing is that we have avoidance goal. It's really hard to celebrate not getting foot ulcer. Celebrating a healed foot ulcer is much easier. You have a problem, you heal it, and then you're there, which is a goal that for patients and clinicians is easy to work towards. And in psychology, we see that avoidance goals, like not getting something, that's quite challenging. Then if we look at healing foot ulcers, we have multidisciplinary treatment with huge multidisciplinary teams all working together to heal that foot ulcer. But once healed, often patients go back to community care where there is nothing multidisciplinary and where it's really hard to sort of have multiple clinicians in the same room. But why do we put in 10 clinicians once there's an ulcer and maybe only 1 once the ulcer heals? Can we create better multidisciplinary ulcer prevention team to sort of supplement the multidisciplinary healing teams? What we're also seeing is a lack of industrial engagement. If you walk around at the conferences, you see all these big wound care companies, but you hardly see companies focusing on prevention. So somehow we find it hard to monetize prevention, even though we all know a dollar worth prevention is worth hundreds of dollars in cure. But we somehow find it hard to get industry truly involved, and we need everyone to prevent the ulcers that are coming to us. And I also think that we still don't have enough understanding of ulcer development. Do we really know why this ulcer is happening in this patient at this moment in time? And that's apart from doing everything we can to implement the guidelines that are there right now. We are trying to work now towards a paradigm shift that you see all over the medical world, and it's personalized medicine. And we would like to apply that to diabetic foot disease. And personalized medicine is big in cancer care, it's big in heart disease care. So why not in diabetic foot care? And here's the same graph showing you this is how we can do it. This is how we can implement personalized medicine for diabetic foot disease. Because look at these three patients. The first patient is an elderly woman who's had multiple ulcers in the past, all on the plantar side of the foot, and has just recently healed from her last ulcer. Then we have an elderly man who's had continuous ulcers for a very long time. And we have a younger woman who's had a dorsal ulcer a couple of years ago. According to the current guidelines, all these patients are at high risk and all have the same treatment recommendations because they are at high risk. And that's when, for a personalized medicine perspective, you probably ask yourself, are they really at the same risk? Are they all at high risk? Isn't there differences between them? And should they really have the same recommendations? Shouldn't we have a much more personalized and much more specific recommendations depending on your specific situation? And that is what we hope would be possible if we start to work towards personalized medicine. To zoom in a little bit more in that, these three patients, they should all get an individual assessment and personalized treatment plans. And yes, these treatment plans follow education, footwear, and risk factor treatment. But for some people, education is by a smartphone. For some, it's much more face-to-face talking. And for some, it's just a home care nurse who comes and does a little bit of talking on the side as well. Footwear for some is a shoe, for some just an insole, and for others it's just something inside the house because they hardly leave the house. They just need really good footwear to be used inside the house. And risk factor treatments, yeah, for some it's an orthopedic surgery, for some it's a foot and ankle exercise program, and for others only making sure that these pre-ulcers really stay away. And that the aim of personalized medicine is to get the right treatment to the right patient at the right time. But we have to ask ourselves, do we know what the right treatment is for this patient at this moment in time? And how do we make guidelines to help you get there? And I don't have the answer there. This is really something I also hope the discussion will help us later on. But current practice, we're primarily in ulcer prevention looking at the classical risk factors, neuropathy, PAD, foot deformity, and ulcer history. And that's probably about it. And in personalized medicine, ulcer history should not be a yes or a no. It should be, okay, when was your last ulcer and where was your last ulcer and how long has it healed and what's the skin quality actually at the place of the last ulcer and what's the skin quality in the rest of your foot. And then the key areas in my research career, but also the key modifiable factors. What can we do with patients? We can't change the neuropathy. We can hardly change the PED or the foot deformity, and we can never change ulcer history once it's history. But you can change the biomechanics, and you can try to change people's behavior. We can look at their pressure patterns, their physical activity patterns, their capacity, their opportunity, their motivation for self-care, their socioeconomic situation, their psychological distress, and on different factors that I think as clinicians we're all taking into account already subconsciously, and that's what we have to sort of bring that forward and do that in a more objective way and in a quantifiable way. And so this is the moment that I'm now hopefully saying we should not be smoke alarms. So just sit there and start beeping when there's something wrong. No, if we really want to take ulcer prevention seriously, we all have to become medical detectives. We are the medical detective sitting in front of the patient and trying to prevent the next murder, because the next murder is the next foot ulcer, because we know that ulcers kill and we know that amputations kill. And we are the detective. We know that the
something.
Murder has taken place. The first ulcer
Not here.
But how do we make sure that that's it, that there's not going to be another an ulcer happening? And that's, I think, where the big challenge lies for all of us clinicians in ulcer prevention. And the way to get there is by personalized treatment plans, to get that right treatment to the right patient at the right time. And that requires an integrated approach where you look at education, footwear, and risk factor treatment from all different angles for this specific patients. And we're looking at technological support. And if we manage to do that, oh, and finally, we need more positive goals. We should not only focus on preventing the foot ulcer, but actually, can we coach these patients to become physically more active without getting a foot ulcer? And that we dub safe physical activity, because physical activity is good for your mental health and your physical health. And if you do that without getting a foot ulcer, it's even better. And we should celebrate. We should celebrate patients who spent a year in remission. If you haven't had a foot ulcer for a year, that's a moment to sort of reflect and celebrate that you've had this sickening disease, but you've been ulcer free for more than a year. Like people do in cancer, celebrate it, make it positive. Because if we look at these barriers that I presented earlier, barriers in why are we not prioritizing ulcer prevention, let's look at it in a new light of the slide that I just presented. We can cross out all these different barriers. Avoidance goals can be changed into positive goals, which makes it easier to focus on ulcer prevention and actually more fun. If we do it in an integrated way, we can make multidisciplinary prevention teams, which makes it fun to work together, and where we support our professional colleagues, and where we then work together to prevent those ulcers and to work together with the multidisciplinary healing team. And if we do this based on technological support, that's where industry can come into play, because the technology requires industry to develop technology that is safe, that is reliable, and that can be used at all times and at all places. And finally, in order to sort of get a better understanding of really what happens in ulcer development, we need more research, and we're continuously working on that, and not just us, but many others. But one project that I do like to emphasize here is a dialect project where we have 11 PhD students all throughout Europe focusing on how can we better understand ulcer development and how can we prevent that. And the website is there for those who haven't seen it. We're halfway the project, and that means that 11 young PhD students, highly ambitious, are now getting to the result phase. And you hopefully will hear a lot more about this in the 2 years to come. And that brings the talk to an end. And what you now see here is that, no, it's not about the smoke alarm. It's about being a medical detective. And it's, yes, current practice is stratified healthcare, which is something that we can definitely implement better. But if we can upgrade that to personalized medicine, then we probably can really make big strides towards what we try to achieve with our guidelines and with all the work that all the people in this audience here are doing in preventing foot ulcers in people with diabetes. And with that, I would like to thank you very much all for listening to me.
Thank you very much, Jaap. Fantastic, precise, excellent message. I'm sure it will be very clear to globally, especially in low and middle income countries. I already see a hand of Vijay, but before that, let me just start ball rolling. If education has no effect on preventing foot ulcers, what does this mean in ulcer preventing treatment? What is the role of education there?
Yeah, great question, Abbas. And this is one I've always struggled with, because education is the most accessible part of ulcer prevention. It's what we can all do, no matter where we are. As if you're sitting in front of a patient, education is always at hand. So I think it's the biggest tool that we all have. But the question here is, do we know what the best way of education is? And the second part is, always be aware that education is just a tool. With education, you're not preventing the foot ulcer itself, but you create a fertile ground where you then can install your treatments, and where you can help patients to have better self-care, where you can help family of patients to support the patients in this self-care. So yeah, that's, I think, why we also always focus on education, but always be humble there that just the education is not gonna prevent that foot ulcer. You really need more around it.
Thank you, Jaap. Okay, Vijay, you had a hand up. You can start.
Dr. Jaap, fantastic lecture. We are proud to be a part of the IWGDF guideline 2023. Now, when you say personalized medicine, does it involve a fast-track pathway, which in Italy, in Rome, Marco Meloni showed? So can we link personalized medicine, the right treatment to the right patient at the right time, to the fast-track pathway?
Oh, absolutely. I think if you look at so what I tried in this talk is focus on also prevention, and obviously the fast track pathway is where prevention has been unsuccessful and where the ulcer did develop, and then it's about how do you get the patient at the right place as quick as possible. But what I do think is if we implement personalized medicine for ulcer prevention with multidisciplinary prevention teams, then the fast track pathway becomes much easier because you sort of you close the gap between what we now see also in my country in community care where people are in the first line of treatment, and then you get them in multidisciplinary care when the ulcer has been there for 2-3 months, and you go like, we should have seen this fast tracked 2-3 months ago. I definitely think that sort of it's about marrying the multidisciplinary healing teams with the multidisciplinary prevention teams that is creating the huge gain, because we're not going to prevent every ulcer, absolutely not. But every ulcer that you see much quicker than we're seeing right now means that you can heal them probably also easier.
Thank you, Jaap. Okay, Professor Shakawi, your hand is up.
Yes. First of all, thank you very, very much for the wonderful lecture, informations, and everything is great in this lecture. I want just 2 points to ask you about. In one of your slides, you said that the risk is from the low sensation, low protective sensation, and peripheral arterial disease. I think also we can add all the factors that can retard healing of an ulcer have to be included as hypoalbuminemia, whether from diabetes, which is well known, or from concomitant liver disease, anemia with dehydration, or even food deformity. These are high risk factors for this ulcer. This is a point. The second point is the education. Education is very nice, but I'm sorry, usually of little value as regard limb salvage and wound healing. If we want to make the education fruitful enough, we have to make structured curriculum accredited from you and from the working group, the great working group, and also to be followed by examination and evaluation to give a certificate that this man can deal for diabetic foot salvage. He is able to do this. And after that, we can ask the syndicates all over the world to help to have a specialty for diabetic foot salvage. Now, in my country and in others, the dermatologists play in the callus until it became ulcer. The plastic surgeon can play. Anybody can play with the diabetic foot. The nurse can open and do the dressing. The barber can try because he is not forbidden to do that. And so if we give a point that we have to make a specialty called diabetic foot salvage, this will save a lot of patients and a lot of food. And the International Working Group of Diabetes and the DFoot International are great organizations to initiate that, to initiate this specialty, and to make the curriculum, to make the training course, and to make the evaluation, and to ask others to do the same. Same like the FRCS for surgeons in England, MRCP for the physicians, European Board of Vascular Surgery for orthopedic, for everything. We have to do something like that. But specialty of diabetic foot ulcer and limb salvage is now no man's land. anybody can touch and do whatever you like.
Yeah,
And
and you're
if
totally
you
right.
learn one, the other one will not learn. But if you get, no, nobody can touch the diabetic food except if he have training, education, and license. This will be the end of this story. If you remember general surgery in the past, in the 60s and 70s, we were doing the kidney in the stone, we were using anything. Now, urology is away and became advanced and became not corrupted. Orthopedic surgery was the same. And so we have to put in mind that this is our end target so that we can complete the picture and help honestly for that. I'm sorry to speak too much. Thank you very much.
I think that's a great point that you're making. And going back to the first point you made about risk factors, I think what I try to say is we start with people who have loss of protective sensation and PAD, but obviously once you have that, there are huge risk factors on top of that. But yeah, for the sake of time, I didn't want to go into that. But yeah, you're totally right. There are many more risk factors that we know of and that you should be taking into account. But to make it sort of easy as a starting point, that's where loss of protective sensation and PAD come into play. And yes, we need many more professionals that are adequately trained to care for it. And that starts by advocating that the burden of this disease, and that's the work of Peter Lazzarini, showing that the burden is this big. We need more healthcare professionals, and that's what we're hoping now, sort of with selling the medical detectives, is that actually this is not only important, but it's also really interesting work. And hopefully, well, bring in other people in to come and care for this very complex disease.
Okay, thank you.
Thank you, Jeff. Thank you. Anybody else from the panelists? Okay, Jeff, meanwhile, they're thinking, if we cannot measure the plantar pressure, how do you know the footwear is adequately?
Yeah, great question. Well, I did consider trying to get those slides in, but that would mean a lot of extra talk. But what we are working on right now is to translate all the knowledge that we have from doing pressure mapping into footwear advice. And so Siko has made an algorithm that's showing with each different type of deformities, what are the elements that you need in a shoe where there is evidence. And right now within the Dialect project, we have a PhD student who's going through thousands of articles, looking at all the evidence in even more detail to really be able to give a recipe to people. If you don't have pressure mapping, well, if you follow these set of rules, then you are much more likely to be creating a shoe with lower pressure than if you simply do, well, whatever you want to do. So that's what we're trying to develop right now. And obviously, yeah, measuring pressure will always be better, but this is the second best way of what we're going to achieve. So hopefully you'll see that in 1 or 2 years' time, when Isabella Gigante created that tool, we'll hopefully present that in The Hague in 2027.
Thank you, Jeff. I think Beata, your hand is up.
Yes, thank you
can
very much.
ask.
Thank you, Professor Netten, for an excellent lecture. My question is how to measure the effectiveness of the preventative programs, because as you shown in one of the first slides, the only perhaps 2 or 3% of the studies are focused on the prevention and the others are focused on healing. So this is the first, how to measure the effectiveness. The third, comparing, for example, your country and United States, how many percent of the budget is spent for the prevention, comparing into the healing?
So to the second question, I really don't have the answer. But I do know that in the Netherlands we are quite lucky. So podiatrists do get a little bit of extra money to prevent foot ulcers, which is for a high-risk patient. A podiatrist has around 600 euros a year for the checkup, as well as for multiple risk factor treatments. And then patients are entitled to protective footwear. So I think, yeah, we are quite lucky, but still, I think most of the money will go into ulcer healing, because healing and amputation, and also as the cost paper by Bas has just shown, are just so much more expensive. And then even in our country, we've shown that an orthopedic indoor shoe is really helpful in increasing adherence. We had the healthcare insurance part of the project, and when we were just getting the results, they pulled out of the project and they said, oh, but we're not paying for that. And so you've worked together for years, create this beautiful product that helps patients, and then the health insurance companies pull out. So it is a continuous debate, and that brings us to the other question that you're asking. The only way to show this is to get valid, reliable data from a population level on the number of ulcers and the number of amputations on a yearly basis. And that's where you want to be able to show that number of ulcers are reducing, number of amputations are reducing, because, yeah, as I said earlier, it's that avoidance goal. Nothing happens. So nobody sees the ulcer that didn't happen. So you really have to show in the data over many years. But getting high quality data collection on ulcers, that's a challenge that I haven't solved yet. And I don't see many countries where they've find a way to solve it, because ulcers are as Professor Jaap just said, all over the place, and everybody's caring for them. But that is really what we need. We need to know how many ulcers develop in your country each year, and then can you show that these numbers are reducing? That's when you can show that your ulcer prevention programs work.
Thank you.
Thank you, Jaap. Thank you. Anyone else on the panel? I see no questions from, oh, there is one question. That's a comment. Okay. Anyone from panel?
Yes,
No.
okay.
Yeah. Yes, Shakal.
Yes, I want to comment on the pressure changes and how to support the patient from having an ulcer while moving. The soft silicone pads and the short sockets helped much my patients, to prevent or to delay the appearance of an ulcer. And as you know, the pressure map is changing maybe every 2 weeks or months or 2 months maximum, because the bones are gliding, new fracture, new rotation. So it's not fixed. I will make map now, it will be very nice. I will make something, but after 1 month, it will be changing. And so the local silicone stocks, sockets, and pads are very nice protective device. When I'm going to make shoes, big one, so that mapping of the pressure will be beneficial for a limited time.
Thank you, Shakal. We still have a couple of minutes. Okay. Jeff, maybe the last one. You suggested that personalized medicine. So, but already everybody is doing personalizing treatment. Any comment on that?
Yeah, this is where I have sort of been pulled back as a researcher. You go like, we need to do this, and then many clinicians that I work with said, but I'm already personalizing my treatment. I'm doing this. I look at the patient in front of me. I ask about their history. I ask about who is the support people, and then we sort of try to work towards that. So I think that actually personalized medicine is something we've been doing for decades. But what we need to do is to do that as objective and as quantifiable as possible, because we're all inherently biased, and we make different decisions also depending on what the patient tells you. But if you haven't asked it, and so if you can, if we can work towards more standardized questions and more standardized assessments to really get the information that we need, and to really show, well, if this and this happen, if this and this is present, then this and this is more likely to happen. And with cancer, we're doing it with genes, for example, and we look at if these genes are present, then this is a more likely therapy. But why don't we do that for behavioral traits in people with diabetes? If we measure this and this trait, then this and this is more likely to happen. And when we started measuring and I started having discussions with my doctor, they had to admit that, yes, they thought like, oh, this is a person, lower education, well, probably won't use these shoes doesn't really understand it. And then I measured it and then find out, but they really understand and actually using a shoe all the time. And we had to change that treatment. So it's about doing it as personal as you're already doing, but then based on as objective information as possible as that you can collect.
Abbas, just one comment to I think we have to the IWGDF guidelines 2023 stratifies the patients into those which has been seen once a year, once in 3 months, once six months. It's not happening. The patients are told, people are with ulcer are told to come back after 3 months, but they don't come back. We offered free treatment, they don't come back. They feel that we will admit them and it's out of pocket. It's not insurance covered. So I think IWGDF, we have a lot to learn from IWGDF guideline and a lot to improve on that also. I think the personalized medicine is not being followed now, unfortunately. And I think in 2027 guidelines, it has to be given more importance. Thank you.
Great, noted.
Thank you, Jeff. Okay, so if there are no more questions, then I think this was a wonderful session. We really liked it. It was really nice, very interactive. Before I hand over to our President-elect, Professor Harry, to give a vote of thanks, which is always a tradition in DFOOT International, I would just like to mention that we will see you all on 7th of June, 2025. Professor Sikobos, that will be the last webinar in this term on a very important topic for especially, again, for low and middle income countries, biomechanics and offloading. Harry, all is yours now. Harry.
Thank you, Abbas. I think firstly, I would like to thank Dr. Jaap van Netten, who actually has done a superb job basically in terms of prevention of diabetic foot ulcers. Now, I think two aspects here basically is number one, prevention of actually primary cases and also prevention of those secondary cases, those that we have treated. And I think to echo what Vijay has mentioned also, I think we need to make sure that the IWGDF is not only in the hands of endocrinologists and rehab physicians and all that. Nowadays, we have got family physicians in most of the clinics and the general practitioners and all that. So they have to actually follow these guidelines. And that's important to actually, Abbas, to think about other things, how we can do the implementation. And I would like to thank Jaap, basically, when we actually met in The Hague in 2023, basically, we actually were in a discussion group in the workshop together, and it was beautifully run. I mean, that's how the workshop should be, where everyone actually collaborates and talks and basically comes to a good point itself. So with that, thank you, Jaap, for your session. And at the same time, I would like to thank the board of DFOOT International, together with the chairs and also the regional groups from all the 7 regions of DFOOT International, as well as our sponsors, basically, Go Medical, who has been a major corporate sponsor for DFOOT International, and all the delegates who have been here. Same with our secretariat also, which has been running the webinars, all that. And it'll be the second last session until the next session on the 7th of June. So thank you very much for a fantastic webinar on a Saturday, especially. And
you have some questions.
Yeah, Gulapa, you have a hand? Vijay says? No? Yes, carry on.
Okay, no problem. Right. No problem. Okay, I think what the college is going to say is time up. So anyway, have a good weekend. And thanks to Jaap again. We'll meet you soon, basically. And to everyone, a pleasure meeting all of you all.
Thanks.
Thank you. Take care. Good night.
Thank you very much. Thank you, Jeff. Thank you very much. It was very nice. Thank you. Okay.
Bye-bye. Good.